Today we're going to look at some of the theories explaining schizophrenia. And, not surprisingly, these are going to be fairly disparate, fitting with our multi-dimensional model. A big piece seems to be this biological vulnerability. But there's also a variety of things that are unusual here. So we're going to look at viruses and infections. We're going to look at some genetic pieces. We'll also talk some about some of the brain pieces, particularly brain loss, as well as excessive dopamine. We'll talk some about psychological vulnerabilities. So, these include some of the cognitive deficits that we've already talked about, academic problems that come at least in part of having lost late adolescence. Substance abuse and depression certainly don't help and probably increase problems. And a lot of stressors, including problems with social support and problems with family or within families, particularly in terms of expressed emotion. So one of the things we know about schizophrenia is that people with schizophrenia have more difficulties with attention. And, think back to some of the things that we talked about or that you read in the last video. And one way of thinking about the problems of, the unusual cognitive pieces seems to be that there are problems with distraction. And you might consider watching the Anderson Cooper video posted on D2L and think about what it might be like to listen to voices throughout the day, some of the distractions of the voices and how that might interfere with ability to perform well, but also some of the negative tone of the voices and how that might impact your behavior. Second thing to think about is the role of genetics, and we've talked about this before. Schizophrenia seems to be a pretty heritable disorder. If your twin has schizophrenia, has been diagnosed with it, then you're about 48% probability of doing so also. If both of your parents were diagnosed with schizophrenia, about a 46% probability, and considerably higher than other groups where we're seeing less relatedness. Another thing to think about is that schizophrenia seems to be associated with lower SES, social economic status. Although about 1%, or throughout the world, about twice that in the urban poor. So in one of the first videos, I showed you a photo of densities of diagnosis with schizophrenia in urban Chicago area. And you could see that it was greater in some of the urban poor areas. Now, part of that might be due to urban poverty and some of the stressors associated with that. It might also be a downward socioeconomic drift, which you see in this image. So that if we're looking at socioeconomic status of our patients' fathers and of their brothers, significantly higher than of the patients themselves. And notice that the fathers and brothers are much more similar in status. One of the things that seems to be interesting or may play a role is in terms of birth month. And that seems to be related to exposure to viruses. And you'll notice at first that people born in June are much more likely to have a first admission or to a psychiatric hospital than people born, for example, in the fall and winter. We said that one of the things we might think about is what happens in terms of brain function. And it appears that there is a loss in brain tissue, and you can see in the oval area that there is a that the ventricles, those sort of butterfly-shaped holes in the brain, are larger for people with schizophrenia than not. Or if we're looking at treatments for schizophrenia over the last century, we see that there are many more, there was over the 20th century, there was a significant increase in hospitalized patients, significantly. And that began to drop as some of the psychiatric medications were introduced. Chlorpromazine or thorazine, which is another name for it. We begin to see a drop in some of the psychotic patients. Imipramine, which is a tricyclic antidepressant, we see an additional drop, and the same with lithium. One of the things that you see with this man who had never received Haldol before, or haloperidol, another name for it, less activity, in various parts of the brain. Once the Haldol has been administered, you see that there has been greater activity. Those yellow and red parts drop out. These are all, Haldol, one of the things it does is it increases, it's an antipsychotic, and it decreases the amount of dopamine in the brain. So look at that last line, so this part here. And you see that with schizophrenia, we have disordered thought and behaviors treated by an antipsychotic, which tends to decrease the dopamine in the brain and calms some of the disordered thought and also causes some stiffness and tremors. Now let's look at two other kinds of problems. Amphetamine psychosis, so taking in too much amphetamine, which causes some psychosis, hallucinations, paranoia, which is generally treated with an antipsychotic, decreasing dopamine and calming the person. On the other hand, Parkinson's disease, which is a neurological disease that causes some dementia, most notably a lot of stiffness, motor stiffness, and tremors. The treatment for that is a precursor for dopamine, L-DOPA, and administering that, which then crosses the blood-brain barrier, increases dopamine and reduces some of the stiffness and tremors. So if you compare the amphetamine psychosis with schizophrenia, you see, very similar kinds of responses. And if you're comparing the Parkinson's with the schizophrenia, you see that it's almost mirror image, that schizophrenia causes increases in dopamine. Parkinson's is associated with decreases, and that the effective treatment tries to even this out, and if there's a problem, produces symptoms of the reverse. So what should you do now? We've been talking about a multidimensional model throughout the semester. Are you feeling more receptive to such models at this point? And if so, why? Are there still some models that you're more favorable toward? And why? And take care.